taking shape when I and Dr. Srinath Reddy were discussing how to go about. We were looking at the institutes in the US, the centers of excellence, and how do we sort of replicate that in this country. I think one of the organizations which really gave us the encouragement and then the confidence was the Association of the Schools of Public Health, and Jim was at the time heading that in that association. The second was when we tried to put it into operation, to develop, to conceptualize the whole thing, then I think it was McKinsey's which came in and helped us. So we are really, I think I must acknowledge now that these two institutes, the Association of Schools of Public Health and the McKinsey's, have been instrumental in shaping our thinking at that stage and to take it forward. And I would like to acknowledge that, otherwise I'll be failing in my duty. And in the last 9 years, Dr. Reddy has listed quite a number of achievements, but cutting across all of them, I can pinpoint 3 important areas where I think this particular foundation has excelled. One is, I think the focus of the country and its planners and thinkers into public health, I think has been shaped by the Public Health Foundation. Because I can see the scenario in 2004, there were hardly any public health schools in this country. There were 1 or 2. I can only think of Sri Chitra Tirunal Institute. Otherwise, we never had. And today we have something like 29 and odd. I don't say all of them are of the same excellent standard, but at least interest in public health education has come in a big way in this country. And I think one of the main reasons is the Public Health Foundation and the model we have created. The second important thing is, for 9 years, we have been able to fight out the independence of Public Health Foundation. It is not a happy hunting ground for political interventions at any level. It is a public-private partnership, and it is autonomous in its true sense. We have all the support of the government without any interference from government. And I must congratulate the government for that they thought it an institute which can be left to manage its own affairs and not to sort of get into the day-to-day functioning of it. The third is, I think, the technical support that PHFI has provided to a number of activities, not only in government but outside government also. And many of you know the path-breaking report on universal health coverage was possible only because of the involvement of Public Health Foundation and Dr. Srinath Reddy in that. And that really set the trend for many things to happen in this country. So we can definitely look back with a lot of satisfaction, a lot of pride in what the PHFI has done in all these years. And to commemorate that event, I think we have Jim Curran here, and I don't think we can think of a better person than him to speak on the subject of what has been given to him, that what public health can learn from HIV/AIDS. I think both of us traveled this distance for quite some time, but he is in this for much earlier in that. He is associated with this since 1981. I think when the first task force was set up in the Center for Disease Control on HIV, when many people didn't know what HIV was. Since then, he has been in this. And we were just discussing before we started this meeting. Well, there are 2 very contradictory opinions about HIV. One is that it is a great success, great public health success. In about 20-25 years, we have been able to turn around an epidemic which had otherwise been another plague. But I think the world has succeeded in sort of getting to terms with this. We have not completely won the battle, but I think we have reached somewhere where we can confidently think of the next 20 years for ending AIDS as a public health threat. And as some of you know, the next Sustainable Development Goals, which will be set up in September in the United Nations, it will have one very strong goal of seeing the end of AIDS as an epidemic, as a public health threat. 10 years back, we couldn't have even thought about it, but I think we are there now. So that is the outstanding success. But on the other side, there are people who criticize that AIDS has sucked away resources from public health, from other priority areas, from health system strengthening, from TB, from malaria. I think this criticism is rather misplaced, because the success of AIDS is in pulling out resources from countries, both donor countries as well as developing countries, into a public health program. Why the other programs could not do it? It's not because resources have moved away from public health or other programs, but AIDS has been able to project the urgency, the importance of the agenda, I think to see that the political, the opinion makers and the policy makers have been able to see its importance and put resources there. I think this is a lesson which other programs need to learn, which health system strengthening need to learn, which TB need to learn, from malaria need to learn, cancer need to learn, how to pull resources into priority areas. And the second important thing about HIV is the community involvement. Where is the community involvement in other public health programs? Very little. I think that is a real difference between the success of the AIDS program and not so much of a success of the other programs. I think I don't want to prejudge the issues and didn't want to steal the agenda from Jim Curran. He will be elaborating it much more. But I think some of these issues are of great relevance to us today as we are moving into the next phase of the public health programs. There are many challenges, and Public Health Foundation, I think, is the right organization to steer it forward and to work closely with the government and also with civil society in taking this agenda forward. So with these few words of introduction, I have great pleasure in handing over to I think maybe to Jim. Will there be an introduction? Or, yeah, I think I'll.
So thank you, Dr. Rao. Dr. Reddy, Dr. Swaminathan, colleagues in the audience, colleagues on the panel. It's great to have Dr. Rao here because he's a man who I've respected for so long in his public health role and his HIV role. And he has gone on from being Minister of Health to working throughout the world on this global problem. And it's good to have Dr. Swaminathan here because she can help correct some of the things I'm going to say about TB in India, which is a borrowed topic for me. I'll get it right. But I'm particularly honored to be here because of the Public Health Foundation of India and the leadership that all of you have shown in making this happen. I was fortunate to play an extremely small role, thanks to Dr. Rao describing it as larger than it was, on the founding board in watching the even younger but already famous Dr. Reddy take on this challenge. And he taught me an awful lot of things. It was described as something that would be difficult because it was changing what was being done in India. And it was going to do a number of things at once. Established in a private-public partnership way, institutions throughout the country to train public health professionals and people who were already in practice public health, and to simultaneously become engaged in important research questions for not only India, but the region and the world, to publish these papers, and to be engaged in policy in the nation. All of this was going to be done at once from an organization which didn't really exist yet. And it took someone with enormous credibility already, who was already famous and already had a great job at Ames, didn't need to do this, but said, I'm going to commit myself to this project, and I'm going to do it with loyalty, with strategic intent, and I think importantly, relentlessness to get this to happen. So I'd like to publicly now give a round of applause to the founder and to the 700 colleagues that he's recruited to work on this project. So HIV, what does HIV have for the world? It's a new disease, and I guess I've been there since almost the beginning of its recognition, probably even before the beginning of its recognition. William Osler was a Canadian physician who moved to the United States to be the first head of Johns Hopkins Hospital and one of the founders of Johns Hopkins Medical School, is often thought of as the father of American medicine. And in the introduction to his book, he said, "He who knows syphilis knows medicine." Well, there's two things about that. One is, of course, syphilis was a multi-organ disease. It was a disease that people shunned and paid no attention to, but it had protean manifestations. And he was quite courageous for somebody at the head of the nation's first great medical school in the United States to be able to go to syphilis, which most people were trying to avoid treating and avoiding those dirty patients that got syphilis, and say, he who knows syphilis knows medicine. I wanted to get people involved in AIDS, so I used to tell incoming EIS officers and incoming people at CDC, he who knows AIDS knows public health, and then ultimately he who knows AIDS knows global health. There was similar pushback, and I wasn't William Osler, but we did this because we thought that there were lessons to be learned, and that rather than subtracting from other people's efforts, there was a new problem which ultimately would become the fourth leading cause of death in the world. We didn't know that then. And that we needed to reinvent ways and invent new ways to deal with this problem. And I think now, I hope, can provide lessons for others. There's two things to think about when you think about AIDS. A lot of you are so damn young. Boy, you look young out there. When you think about 1981, you weren't even born yet, let alone, but there are those of us who were around then, who were actually professionals already, and we know that AIDS is a new disease. It's not newly discovered. Oh yeah, a few chimpanzees had it maybe 100 years ago or 75 years ago. But for all practical purposes, it's new to humankind. It wasn't an epidemic in East Africa or South Africa. It certainly wasn't in India, and it wasn't in the United States just a few decades ago. So a new disease can come along and can become the fourth leading cause of death in the world and create a lot of disruption. The other major thing about AIDS is that it's very complex. A lot of us like to talk about the biologic complexity of it and the mutations in the virus, but it's equally socially and culturally complex. And because of that, it has lessons, because so many of our public health problems are complex. Another thing that I think is important when we think about chronic diseases is it's a global disease. I was talking to some reporters about our pride in the newly formed center. And they said to me something that people used to say to me in the 1980s. They said to me, I thought diabetes and cardiovascular disease was a disease that affected America and Europe. What are you doing saying it happens in India? I mean, a reporter said this. And I thought, that's what they told me with AIDS. I thought AIDS was an American disease. I thought AIDS was a gay disease. That doesn't happen in India. It doesn't happen even in Africa. But in fact, we have a lot to learn from each other, and we're best off learning from problems that affect the globe, not only affect one country or another. It's not a problem. They said to me, are you coming to India to discover diabetes? I said, no, we have a lot of it in the United States. We're coming to learn from each other, and that's, I think, applies to AIDS. So AIDS is this type of problem, and I'm going to deal with this by talking about 4 points. What I know most about is what happened in the beginning, predominantly at the CDC and in the United States. Some lessons we got from that. I'm going to borrow from my colleague Neil Gandhi, who works with colleagues in India, to talk about TB in India simply as a backdrop for thinking about how they fit together, and then go back to lessons from HIV for chronic disease. So first of all, since I'm talking about history and that I was involved in, this is totally unbiased. If you believe that, then you're naive. But it began with the first 5 cases of pneumocystis pneumonia reported from Los Angeles to the CDC. CDC was fortunate because in order to treat pneumocystis pneumonia, if Septra and Bactrim failed, you had to request a drug called pentamidine isothianate from the CDC because it was only available from the CDC. There was a clerk there who had worked with another infectious disease physician, and they had published an article that from 1967 to 1981, there was only one request for pentamidine in somebody who didn't have underlying cancer immunosuppression. This clerk, Sandy Ford, told her supervisors, there are people requesting this for healthy gay men in New York and California. So Dr. Michael Gottlieb, Dr. Ostro, and others reported to the veterinarians in this particular group that there were 5 cases of pneumocystis in previously healthy gay men. because I was chief of the research branch of the STD division at the time, and we had a hepatitis B vaccine trial in gay men, I was asked to coordinate a task force, which we called the Task Force on Kaposi Sarcoma and Opportunistic Infections. Thank God we changed it to AIDS in 1982, because that is pretty awkward. But we called it this because there were some rare cancers occurring, also being reported from California and New York, also in gay men. Kaposi sarcoma was a cancer at the time which had previously only been seen mostly in elderly men, Mediterranean origin, and it was usually a skin cancer with relatively little serious side effects. There were a couple exceptions. One exception was a childhood version that was quite serious in Uganda. It had been studied. And the other was that it was a cancer that occurred in several hundred-fold frequency in transplant recipients who were immunocompromised. And in fact, sometimes when the immunosuppressant drugs were stopped, the cancer would go away. So it appeared to be an opportunistic cancer, and we had some small numbers of reports of that. And we wanted to tie these together because the dermatologists and oncologists seeing the cancer, the infectious disease docs seeing the fatal opportunistic infections, were different doctors seeing different patients for the most part. The first thing we did in surveillance, our job in epidemiology was, is this new? Who's getting it and who isn't getting it? Is it spreading? Is it getting faster? What is it? So we had a case definition, and the most important thing was it being specific and accurate. So if it was Kaposi sarcoma, we wanted to exclude the couple hundred cases in elderly men and women. So we said it had to be people under 60, and it had to be proven by a biopsy. It had to be biopsy or cultural proven threatening or fatal opportunistic infections. And at the time, pneumocystis was only diagnosed in the U.S. with an open lung biopsy. So you had to have a resistant pneumonia for which you could actually do an open lung biopsy to make a diagnosis. Undoubtedly, cases were missed, but it was a pretty drastic case, and we had this specific case definition. And there had to be no underlying illness or history of immunosuppressive therapy. Some of the first cases, of course, were diagnosed initially only to have a cancer diagnosed a few days later. This was highly specific. Patients who had AIDS were often walking ghosts. These people were doctors who saw their first case, remembered it for their whole career. They'd never seen anything like this. So it was highly specific, and that means that if it fit the case definition, it very likely was part of what we were interested in studying. This definition was rapidly picked up by every developed country of the world. It wasn't very useful in Africa because the conditions weren't right for the type of diagnoses needed. We sent medical officers to the 18 largest cities and reviewed all the cases in the pathology logs and infectious disease logs in the major hospitals in these cities in the first month. And we found essentially no cases outside of California and New York, except one in Atlanta who was a medical student at Emory who actually had been from New York. But we knew it lacked sensitivity because as we talked to doctor colleagues in California and New York, and many of our colleagues in the hepatitis B studies, they said, we've seen an increasing number of gay men come to our office with nonspecific symptoms, chronic cytositis, lymphadenopathy that would come and go, unexplained fevers. But we didn't want to describe this by the group. We were trying to determine who got it and who didn't. So we didn't say, well, everybody who's a gay man who's sick has this. We said instead it had to fit this specific definition. Our first peer-reviewed publication came at the end of 1981 in the New England Journal of Medicine. And this is how the New England Journal used to have slides. This is for the people who were born after 1981. And these are cases, the first 159 cases. There were 158 men and one woman. And most of the cases were in gay men, except for a few injecting drug users who were fatally affected by the time they were diagnosed. A couple important things. One is that we could find no cases before 1978, and these are the date of onset of symptoms. So by date of onset of symptoms rather than date of report, there was a clear trend upward, and then it drops off because the onset of symptoms of late reported cases were later. Secondly, 50% of cases were pneumocystis carinii pneumonia, 40% were Kaposi sarcoma, and important to us, 10% of cases had both. Now this seems so obvious, except that they were different doctors in different parts of the country, and they didn't believe each other. Can you imagine specialists not believing each other? And then we also emphasized how important that there was an iceberg. People with thrombocytopenia that was unexplained, lymphadenopathy, some unusual lymphomas, and a variety of other conditions were here. Now, since we'd been studying hepatitis B and we were infectious disease people, we believed that this was probably caused by an unknown virus. A lot of people didn't believe that. It was not well thought of that way. But what we'd hoped was this would be a hepatitis B iceberg. And wouldn't that have been wonderful, to have an iceberg in which the clinical illness and the fatalities were at the top, and below it was a form thrust of successful immune response, which could be duplicated in the vaccine, which would result in ability to save the world quickly. That's what we hoped, and we hoped the iceberg was there. Led by Dr. Harold Jaffe and colleagues throughout the United States, we did a national case control study in which cases of men with Kaposi sarcoma and pneumocystis pneumonia, gay men, were compared to a variety of matched controls obtained from STD clinics and private physicians' offices, and compared in the same cities of the same onset of symptoms. They were matched for race also. We knew that there was overmatching from the point of view of sexual transmission, because one of the major reasons gay men went to STD clinics was for STDs and also for private practice offices at the same time for STD treatment. But nonetheless, the variables that distinguished cases of what was then not yet called AIDS from controls were lifetime and recent sexual partners and sexual contact in bathhouses, and also serologic variables increase with other STDs. But people didn't want to believe that this was caused by a new virus and was sexually transmitted. Our Epidemic Intelligence Service officer in Los Angeles is a man named Dr. David Auerbach. David was sitting at his desk one day when a wealthy gay man came in with a scrapbook, and he began to cry and said, "This is a picture of my partner, who was a weightlifter and bodybuilder. This is us on the beach. This is him just before he died of pneumocystis pneumonia. And here's a picture of us in 1978 or 79 at a fundraiser for the gay community with 1,000 people. And we were sitting at a table with 8 or 12 people or 15 people. We got to know each other. We partied together quite a bit. And 4 of these people at this table have died." Sometimes epidemiology is so easy, you know. He looked at this and we said, "What do you think this is?" So Dr. Auerbach worked with Dr. Bill Darrow and our Atlanta staff, and they interviewed, there were 13 cases in Los Angeles, and then they interviewed 90 of the first 210 cases in gay men in the United States. And what they found was there was a patient in Los Angeles, and that 9 of the original 13 cases